समाजासह देशभर and many more. As a former head of the department at multiple institutions, he has shaped the career of countless dental professionals. Also, we have Dr. Rohit Lakhyani. Dr. Rohit Lakhyani is highly accomplished professional in the field of dentistry, specializing in prosthodontics and oral implantology. As a consultant prosthodontist and implantologist at the Dental Design and Implant Center, Dr. Lakhania has over 17 years of invaluable clinical experience and making him truly expert in his field. So I'm Ketna and we have Ragini. So we are going to lead this webinar. So it's our privilege to have Dr. Pandey as our estimated speaker for today's webinar. So please join me in extending warm welcome to him. Before we dive into our webinar, I would like to take a moment to introduce you to the Denti. So we understand the unique need of the dental practitioner, and our flagship software is not designed to streamline the practice management, making it more efficient and effective. So our software offers a wide range of features tailored to enhance your dental, like from the appointment scheduling to patient record management to financial tracking. We are not just a software provider. We are your partner in ensuring the smooth operation and delivering the exceptional patient care. So at Denti, we are dedicated to advancing the dental care through the cut-edging dental software. So today's webinar is part of our commitment. We are not just a software provider. We are also we also provide the valuable education. So we believe in empowering the dental professional with the knowledge, and this session is perfectly aligned with that. Therefore, the Denti education brings the best upcoming dental courses, events, conference, right at your fingertip. Whether you are a dental student, practitioner, or an educator, Denti has something like that can value you. You can not only this, you can register your dental academy, your dental course, so that it's an easy way to to promote your dental courses on internet with the help of Denti platform. So without further ado, I would take a moment and I'll hand over to the Dr. Pandes to take over this stage. Before that, I would like to share one poll so that doctor will join. Till then, sir. Yeah, the second poll, I'm sharing with you all this. Yeah. Okay, fine. Like, what is the prime purpose of dental implant? Management, sharing with you all this. Yeah. Okay, fine. Like, what is the prime purpose of dental implants? So the result I would display. Okay, we got the option B as the highest rated answer, and I'll just publish the result there. Okay, fine. And for the second answer, I would, yeah, this is the C1 is been rated most. Okay. So doctor, you can take over this stage. I think your screen is not visible. Yeah, okay. It's the wrong screen. I guess screen is not visible, doctor. Oh, I will share your on behalf of you. Yes, doctor, you can.
Good afternoon, ladies and gentlemen. I am extremely grateful to dentists and their associates for giving us an opportunity to our academy and to ourselves to share whatever little bit of understanding we have got about implantology to you all clinicians. Next. We all know that there is a structural attachment difference between a natural tooth and the implants. Since there is a structural difference in their attachments as well as the soft tissue encapsulating around it, the whenever a load is being given to the implants, their reaction, the biomechanical difference to the load has to be there because of a limited amount of capturing the remodeling phenomena which is going to be there with the implants. Certainly there is going to be a difference in their load bearing capabilities if we compare dental implant with a natural tooth. We know that whenever you are using an implant, which way it is going to give you the benefits to the individual. They provide help from the emotional point of view. If we see that the implants are going to give you an improved social life because of you being so very confident, you are not having a denture which is going to wobble at the time when you are talking to somebody or when you are eating. Secondly, it gives you an improved self-confidence in an individual. If you are having a well-fixed and aesthetically improved quality of processes, it gives an internal confidence in an individual as well. By having these implant-supported processes, you can have a better kind of speech capability. You can easily speak because if you are having a processes in the anterior region, there are few words pronunciation is going to be difficult with the moving. They have had functional benefits in the form of that you can have an advanced chewing capability because you're able to restore. You are having a better kind of bite force, almost uh, equivalent to a natural tooth. Then you have got an improved aesthetics because we say that implants, whenever the processes is been given, attachment to that is going to become as natural or as close to natural with the implants. We also have studied and we know that there is going to be a lessened amount of resorption, especially when you are placing an implant. The two adjacent teeth, natural teeth, they will have a reduced rate of their resorptions. And along with that, you have got a very a greater kind of comfort because of that fixed processes which has been given, which is not going to move around whenever you are talking. Along with that, I would like to put across one point here is that loss of teeth is going to cause cognitive impairment in an individual, especially that growing population. We have got the elderly people. So most of the time you will find few of the teeth are missing. It is mandatory now since we have started studying about these things and understanding the basic bio physiology of this. We always say that putting an implant is always better. At least the restoration of the lost tooth should be there. And if possible, as far as possible, an implant supported processes will always be better. Mhm. Whenever we are doing an implant, we are thinking of taking up a case for implant procedure. There are following considerations. Basically, one has to take into account whenever you are going to do a clinical evaluation of a case. The first and the foremost is that you have to find out the region of the tooth loss. Why, how the tooth has been lost. If it has been because of a trauma, then we do anticipate that there may be some amount of bony loss. So you need an additional augmentation procedures to be done there. If it is a hypodontia, we have to look for there may be some systemic problems which is going to be associated with it. So you have to be carefully evaluate that also. The dental disease, in case if you have got the caries and other associated problems, we need to tackle those first before we are taking for the implants. And in case if the individual has gone into any kind of surgery like ablative surgery, then we know that yes, later on individual has to go for a reconstructive procedures. As far as the individual patient's health is concerned, we always say that do not try as a beginner. You should try to avoid taking up cases which are medically compromised. But I say that yes, depending on your status or your clinical acumen, you can take up cases. But be cautious whenever you are selecting a case. Evaluate first and then only you take up. For a beginner, even the smoking, we say that individuals, whenever they are smoking, I will advise that as a beginner, do not try to take up cases those who are smokers. Because in a smoker, they have got the influence both ways. They have local factors which are influencing the problems and as well as their absorption and leading into the systemic complications. Evaluation of oral hygiene is very important because this is one single factor which is going to give you a complete uh, information about the individual's protocol. Because whenever we are going to put an implant, we always know that the oral hygiene maintenance protocol is going to be far more better than which is with the natural tooth. We must need to evaluate the status of remaining teeth. We have to find out in case if there is any kind of problem, because suddenly if you are placing implants and you see the two adjacent teeth, they are whether they are okay or not, or even evaluate the whole mouth so that whenever you are giving that implant supported processes or implant retained processes for that matter, there should not be an immediate problem because they may be correlated immediately with the implant placement. Actually, it may not be. Processes you would be planning in that case. Occlusion evaluation status is very important because this is one thing which ultimately at the end of it after giving a prosthesis, you need to have a very stable kind of functional occlusion to the individual, so that he can satisfactorily use that particular processes without any kind of interferences. Whenever we are taking up a case, or whenever we are trying to evaluate cases for implants, it is always there that you should try to look for an additional replacing uh, procedures, whatever other modalities which are available to rehabilitate or to replace missing teeth. The quality and quantity of bone is one single most factor which is going to give you the longevity, the selection of the implants, as well as the longevity of the processes, that how best you can use it and for how long. The quality and contour of the soft tissues is very important, because and if you are not having a thick kind of uh, biological tissue over an implant, they are the implant bone basically. If we are talking about, they basically provide an integrity to the bone, underlying bone. The aesthetic outcome is very important, because if you are going to give an implant prosthetics, the individual has to be, they look for, specifically whenever you are giving processes in the interior region of the jaw, the aesthetic outcome, because they are going at, with the implants, there are provisions by which you can give almost like a natural looking replacement of a natural tooth. At this point of time, I would like to say that patient motivation is very important. You have to see to it that the patient is being motivated properly. Otherwise, in spite of you giving best of the processes to the individual, he will never be satisfied, and he will keep coming back with one or the other problems. In the medically compromised patients, I have just taken two examples as a protocol, and would like to I'd like to give you that whenever you are going to examine a case and you find out that he is needing for an implant and he is coming to you, if their blood pressure at that particular moment of time is between uh, the systolic uh, pressure is between 120 to 130 or 140 even for that matter, and yes, the diastolics ranging between 80 to 89, or you can say 90, then those are the pre-hypertensive cases, and you can easily take them for your procedures. But if you find anybody having the BP in the range of 140 to 160 or beyond, they are the cases which needs to be referred medically, and the medical clearance needs to be taken before you take up this. Likewise, for a diabetic individual, if you are taking up a case or coming somebody with the diabetes and you want the treatments, we normally see that anybody who has got HbA1c of around 125 or 6%, then these are the cases which you can take up without any kind of problems. We say that yes, you have to take caution, and as well as few additional measures has to be taken to see, because they are basically the relative contraindication patients where the HbA1c is ranging between 6 to 8%. And if it is beyond 8, then we say that it is absolutely contraindicated unless somebody has been cleared up by doing other measures with the madmen. I'm giving you one formula actually, where you can see if you have got the HbA1c, you can know that how much is the blood sugar individual is having. So you have the formula of 2.28, 28.7 multiplied by HbA1c, whatever is the amount, you deduct from this 46.7 milligram per day. This will give you the amount of blood sugar an individual is having. The 6 is going to be roughly around 125, and 8 is going to be somewhere around 180. Now we say that do not take up any case beyond 8% of HbA1c, is because we know that the renal threshold is 180 milligram per deciliter. So do not go beyond that. If it is there, then the blood, then the sugar starts coming into your urine as well, which is attachment. So evaluate the case first, and then after that you can take up. in the implant-focused intraoral examination, actually, basically needs one to do a restorative and the structural integrity of the existing teeth and the processes has to be evaluated. The vestibular and the palatal depths, which are very important, specifically in cases where you are going to give an implant retained processes. Periodontal status of the oral hygiene is one single most factor which is going to give you the life of the implant and the comfort. Occlusion is very important because ultimately it is an individual needs to be provided with a stable functional occlusion where he is able to happily, you can chew and use the processes whichever been given to him. Jaw relationship is very important because this will give us that what kind of angulations you are going to give and how you are going to rehabilitate, whether individual is going to be, can he be rehabilitated with a fixed kind of processes or we have to resort to something where removable processes. The interarch space is very important because you have to understand that some amount of specific space has to be there so that we can calculate the crown height space, where basically an implant with a standard processes can be provided into that. Based on that, either it is only about 8 millimeters, then we can easily give a normal standard implant. If it is more than that, then we have to see to it if it is going beyond 14, 15 mm or 18 mm for that matter. If we say then beyond 18 mm, then it will be very difficult for one to place an implant and give an implant supported processes. Those are the cases where you would need, in case if it is possible, a implant retained processes, or you have to go for a conventional processes for the rehabilitation. The maximum mouth opening, which is going to be very important for you to evaluate because the surgical ergonomics is really going to get affected because of the mouth opening. You will not be able to place implants in the posterior aspects of the jaw if you do not have a proper, at least a 3-finger mouth opening. The parafunctional habits is something which is to be taken care of. One has to be aware of it because this is going to be modified, and as a beginner, I will say that you do not take up implant cases because unless you have a fair bit of idea about the implant biomechanics and how you manage the load in an individual, it will be difficult for you to manage those kind of cases, and you might end up with the complications. The intraoral examination, while doing that intraoral examination, we have to go for a very comprehensive kind of examination inside the oral cavity. You have to see the each and every individual tooth and the surrounding soft tissue around that. We have to understand that how much is, what is the status. Now, whenever we are doing a hard tissue evaluation, we have to really do it in a very meticulous way. The available amount of space visually you can utilize, and then you can do the palpation and try to find out the vestibular depth. And whenever you are doing it, at least you can be able to see if there is any kind of concavity is there or not. And even on a smaller level, if you have got limited amount of edentular space available, in those cases, by using bone measuring calipers, you can find out the idea that how much is the length which is available for the processes and what is the width, because that will help you in selecting a proper prosthodontic implant. But by measuring this, because this is a case where you need not have to go for a very elaborate kind of processes or evaluation where. And then the intraoral examination, again, you have to be very careful about the soft tissue evaluation because this is very important. It is the single factor which is going to see the integrity of the envelope, a bone around that implant and its marginal integrity. Here we have to see that what is the health of the soft tissue. You can see going all around and see the area of the overall mouth where there is any kind of problem in this. In case if an individual have got any kind of previous implant placed, examination and evaluation of the area around that implant is going to give you the detailed idea that what kind of hygiene maintenance individual is going to have. So accordingly, you can tackle and explain to him. The tissue biotype is very important because we say that if there is a thick biotype, then in that case it is going to be around 2.5 mm or more than that. If the tissue thickness is there, that is going to give resistance for the bone to the jaw. And likewise, we say that in case if you have got a thicker bone, then even a thinner amount of, because they reciprocate each other. The bone and the soft tissue, they reciprocate each other. It is very important for us to understand and know about the keratinized tissue. Normally, we say that at least 2 millimeter of keratinized width, if it is there, this is going to give a lot of resistance for an external stimulus and affecting or influencing the underlying bone. And there is not going to be resorption into that crestal area. Whenever we are examining a patient, it is very important that you have to evaluate a case based on the surgical aspect of it, keeping that surgical aspect into a mind. A proper mouth opening has to be there. Normally, we say that minimum of 3 finger width should be there. Then only you will be able to, because whenever you are trying to place an implant in the maxillary second molar area, it becomes very difficult for us or anyone to place an implant in a proper axial position. So evaluate this. Not only that, evaluate. You have to see that perioral musculature, whatever is the status. More than that, the radiographic evaluation is, if you have got a very limited area, then you can go for IOPA, and this is enough for you to give an information, because this also gives you a very high resolution informations. But along with that, we normally need many times to use a panoramic radiographs, because this is going to give you an overall structural relationship of the teeth and the adjacent area. Whenever we are taking an implant, normally we say that CBCT is a requirement, especially whenever you are looking for placing an implant in the mandibular or the maxillary anterior region, because the CBCT is the one which is going to give you a 3 volumetric information about that. And here it can give you the length, width, and the height. But it is very important in the anterior region. What happens is, if you have taken the slices of the CBCT, then only you will be able to understand the orientation of the alveolar bone in the maxillary anterior and the mandibular anterior region, where you find, like in the maxilla, if you try to approach towards the nasal crest area, you will find that there is a dip in between. So you cannot take a reference from by taking only the measurement at the crest of the ridge. In that cases, you have to follow the whatever is the orientation of the bone. Your implant placement has to follow that plane itself. The diagnostic cast is very important for you to give a fair bit of idea about that. What is the kind of occlusion this individual is having, whatever the space available, which is there, like in the maxillary anterior region. If you have got, then you know that whatever the amount of space which is available. In these cases, normally we say that even the anterior region maxilla, if you are looking for, we have to see and evaluate that at least we say that a minimum of 10 millimeter of implant length has to be there. If you have got any surplus bone, then in that cases you can do osteoplasty and do place the implants. But if that space is not there, then in that cases you have to modify your kind of processes which is to be given, rather than only straightway taking up a case. Similarly, this evaluation of the diagnostic cost will give you the extension about the cantilevers which are going to be there. How many teeth you are going to provide into that region. That also is very important. In the posterior region, are you having an enough of bone between the maxillary sinus and the crest area where you can place a good 10 millimeter implants and give it? If it is not there, then in that cases, whatever alternative you are going to give, you are going to give an implant retained kind of processes, then the cantilever becomes a limitations depending on the number of implants which can be placed in this successful bone. So you have to evaluate these things carefully before taking up a case. Actually, for implants, whenever you are taking up a case specifically for a multiple restorations. Based on whatever that evaluations we have done, we find some kind of a treatment plan. We have to see that based on the available bone volume, we make some tentative plan that how to go about further. If we find that there is a adequate amount of bone available, in those cases you can go for an implant placement. You can follow a loading protocol both ways, either if it is a stable one and you have got adequate bone with a primary stability better, you can even go for an immediate loading of that implant itself. Or else, if you find that you have not been able to achieve the proper torque, even in spite of having an adequate bone, where the bone density is not very amenable to have that, then in those cases you can place the implant, but wait and then do a delayed loading in those cases. But wherever you find that the bone is deficient, then we have to see that how deficient it is. If you see that by doing only the ridge augmentation, if it is feasible within the limits, we say that 4 to 5 millimeters of this thing is there. In that cases, we can do ridge augmentation, to ridge split with the ridge augmentation, and along with that, we can place an implant. Whenever we are placing an implant in these kind of situations, you need to have a two-stage implant loading protocol. You cannot load the implant immediately at the time when you have placed it. You have to give a specific time of. Normally, I follow that if you are doing in the mandible, or wherever you are using a graft material, we say that normally we take about 6 months of time before we go ahead with the loading. Here we say that there is certain criteria which are given for implant placement, that where and how you are going to place an implant. Normally we say in the maxilla we divide into 5 segments. Whereas the segment 1, normally we say that maxillary lateral and the central incisors of either side of the midline makes one segment. The canine on either side is taken as a 2 separate segments, and the posterior teeth has been taken as a separate segments. There is a rule in placement of implant in these cases. We say that that whenever you are doing implant supported processes, or when you are going to give a bridge, the distal implant has to be there. The processes cannot have a cantilever, only the distal implants has to be there. So there will be an implant at the distal end of it. Then you need a canine molar rule. Whenever you are going to restore, actually the canine and the molar has to be there. The third rule is basically there cannot be more than 2 pontics. If at all you are placing an implant, you have to see to it that there is not more than 2 pontics. Otherwise, this is going to give you unnecessary stress on these implants and the implant can fail. The fourth rule is basically on the arch dynamics. We have to see, because this is basically whenever you are placing and whenever you are evaluating a case, we have to see that what is actually going to be the distance between the canine tip and the labial surface of the maxillary central incisors whenever you are replacing that. Based on that, the arches are basically either a square or oval arch or a tapered arch. Normally we say that the square arches, they have space or the cantilever of about 8 millimeter or even less than that. The oval arches, they have at least between 8 and 12 millimeters. But if you have got a tapered arch, the distance between the labial surface of the central incisor and the canine tip is going to be more than 12 millimeters. So they are the cases. Based on that, we need that where all to place an implant. In a square arch, you can place implants in the canine region and you can get away with a proper processes. But if you have got an oval arch, then in that case, along with the implant in the canine regions, you need to have an implant in one of the central incisors. But if you have got an oval arch, a tapering arch, then in that cases, along with the 2 canines, you need to replace 6 anterior teeth. In the maxilla, we need 4 implants. You cannot get away because the cantilever is going to be more. Likewise, in the implant placement considerations, whenever we are doing it, we have to see it with whenever you are placing, ideally an implant should be placed 3 millimeter below the gingival margin. We have to see that whenever you are placing an implant, between a natural tooth and the implant, there has to be a minimum space of 1.5 millimeter. You can keep a 2 mm, it is always good, but at least minimum, you cannot be less than that, because then here the other soft tissue factors is going to come into play. between the implants, if you are having a multiple implant, then between the two implants, there is going to be a minimum of 3 millimeter of space to be provided. You cannot compromise onto that because the biological width, the horizontal component of the biological width is going to come into a play, and this will cause a crystal bony resorption in between the implants. So whenever you are placing an implant, you and then at least 1 millimeter of bone. We say that ideally, if you can keep it 1.5 millimeter, it is always good. But otherwise, 1 millimeter of bone on either side, on the buccal side and as well as on the lingual or the palatal side, should be there. But this rule is not applied whenever we are doing in the interior region of the maxilla. Whenever you are doing it here, we follow a 3:2 rule. That there has to be implant placement 3 millimeter below the gum margin, but at least implant placement has to be 2 millimeter palatal to the labial plate. So you have to see to it in case if you are looking for a prolonged, long-acting satisfactory implant process. Now we will be seeing the selection of the implant, that what kind of implant you should use it and how you uh, do its placement, whatever the basic protocol we follow. The we say that in the endosseous implant basically are two basic categories we follow. One is that parallel wall are the cylindrical implants, and the one is conical are the tapered implants. These are the ones which are available in the market. For the cylindrical implants, we can choose that implant because the ease of placement is there. In case if there is any discrepancy in the height correction, that can easily be done, which is not feasible with the conical implants. And because of having a greater surface area, they have a very higher initial osseointegration. So initial part of the osseointegration, we say that to provide the primary stability to the implant in a little additional way, they are a better kind of implants. Selection of a taper implant, in case if you are looking for high insertion of the taper implants they give you, it means they will give you a proper kind of better primary stability. So you can plan in case if you are going for an immediate implant placement, you can go with that. And then if you can have immediate implant placement with a proper torque, then that case you can go for immediate loading as well. The implant can also be selected based on their available bone quality, whether they available which is space mesiodistally, buccolingually, and the vertical height. Based on that, you can have implants, whether the narrow implants or the wider implants, you can have this. Then based on their quality, we say that D1, D2, D3, D4, and D5 bone. Any bone, D1 is more than 1250 ounce unit. Second is that 850 to 1250 is D2 kind of bone. Then between 350 and 850 is the type 4 or D4, D3 implants. We say the D3 bone density. Between 150 and 350 is there, say we say the D4 bone is there, and the D5 bone normally we say that it is a very sparse kind of trabecular pattern. You can find the strength is less than 150. If you are going for these kind of selection, then in D1 and D2 bone, try to go for a passive thread implants. Because if you are trying to take any active thread implants, it will be very difficult for you to place that implant unless you go for any kind of additional based on requirements. Immediate implant or the immediate loading will depend on that what kind of specific implant you are going to have. Active thread implant plus the density of that bone will decide whether you can load it immediately or not. Based on the restorative processes, it can be either a screw retained implant or a cement retained implant. Specifically in the maxillary anterior region, whenever you are doing it, you try to go with the placement going on a little more palatal side. Then the thread designs, basically the implants which we come across is a V-shaped thread design is the one which is very easily you can place it. The most of the implants are available in this where the thread design is a V-shape. Then is the buttress thread implant. The buttress thread implants are very good in case if you are putting implants into a softer bone. They are the one which will be an ideal because they will give you more of a vertical load resistance. And they are very good for the compressive load. taking. Then another is reverse buttress thread implant. The reverse buttress thread implant actually will maintain the crystal integrity mode. So they are the one which provide you primary stability mode and the transmission of the load which is coming onto the implant to the sides. They can maintain the mode. And one is that the square thread implant. They are the one implant which are the best. They can provide you the best possible crystal integrity to be maintained even there whenever the load is being given. The implant surface modifier, we know that by simply doing an implant and with modifying, we increase the basic surface area. Because they are going to have an increased anatomical surface area by doing the procedure. You can increase that nano structures because of that hydrophilicity will give improved. This hydrophilicity as well as the nano structured implant surface, they are going to give you a better kind of osseointegration and the faster. That means the increase of osseointegration rate also will improve, and you can find a improved kind of surface properties in this. Right now, there are different generations of implants have come, but we are up to about third generation implant we are using, and beyond that, they are into scientific development as well. They have not come into the market as of now. Implant placement criteria, if you are saying it from the surgical aspects, we normally say whether you are doing with a proper flap separation or you are going for a flapless implant placement. From the prosthetic point of view, so we see that whether the processes which are going to have is going to be a cement retained or a screw retained kind of processes. Or if an implant, then second is whether they are going to be an implant supported processes where the whole of the processes load is going to be borne by the implant or implant retained processes. Now, with the flap versus flapless surgery, we say that whenever you are doing a flap, it will take a more of a healing time. It will need additional suturing is to prevent the bone anatomy or the viral structures. They can easily be appreciated. This is going to be one of the positive aspects of it. But that integrity maintained, whenever you have opened out, there is going to be roughly about a millimeter of bone loss in those kind of cases. So it will always be better that if you are going for a flapless kind of procedure, because they will give you a quick healing time. With the soft tissue management is better. You can do a precise placement of the implant, but the selective indications are there. If you are doing precisely, you can do it, but you certainly need to understand the whole anatomy of the bone at that particular moment of time. The pattern of the two cortical plates. If they are parallel, you can go for. Otherwise, they are going to let you land up into problems. Processes point of view, the cement retained processes, you can see they can easily be done. The problem is that screw retained processes, you cannot go in the anterior region. Posterior region, you can always do, but anterior region, most of the time, if the implant is being placed, then you have to really have in mind that it is going to be a cement retained or a screw retained, because the implant placement has to vary depending on that what kind of processes you are giving it. Ideally speaking, in the aesthetic zone, we try to give a cement retained processes rather than going for a screw retained processes. One, because of their functional region, and the second is because of the aesthetic requirement. Most of the time, if a regular placed implant, you will find that the screw hole is coming in the labial part of it. A screw retained implants, again, there are limitations. Otherwise, they are basically they can provide you a stable process. Retrievability is the biggest advantage with this screw retained processes. A full mouth rehabs you can easily be done. Then we talk of the implant retained processes and implant supported processes. Whenever we are going to go for a implant retained processes, it means that on the distal aspect of the jaw, there is not enough of bone to support the processes. In these cases, that there will be a limited number of implants, and the processes has to have extensions. So it means not only the implant, the soft tissue also is going to get the support. So whenever you are going to get a support from a soft tissue as well as to the implants, the processes is normally we say that the implant retained processes, because there is not enough of bone to place a proper number of implants to bear the load. And whereas in implant supported processes, since the whole load is going to be borne by the implants, we can increase the number of implants normally up to about 6 implants or 6 to 8 implants in the maxilla and at least about 6 implants in the mandible. That's the basic requirement for having implant supported processes. There is a protocol time-wise, the timeline which is being given for the placement is normally we say that immediate implant placement. Whenever you are doing an immediate implant placement, you have got a extraction socket. So that whatever is the residual area after placement of the implant has to be augmented with the graft material. And whenever you are using a graft material, a barrier membrane has to be given. When you find that you are going to give an early or a delayed immediate implant placement, which is happening like after the extraction between 4 to 8 weeks, you will find that there is a significant amount of soft tissue healing is there, but the enough bone has not formed. So these are the cases where again you have to handle and modify your protocols. As far as possible, either you can treat it as an immediate implant cases if you find that the bone is so very soft, or even there is only the fibrous tissue is formed in place of that. Or else, if you find that the bone is very soft, then you can modify it by osseodensification kind of phenomena you can use in these cases. Delayed implant placement, whenever you are doing it between 12 to 16 weeks of there, here you have got enough amount of the significant soft tissue healing is there and the significant bone healing also is there. So you can easily go ahead and place some implants. The 6 months are beyond that. Whenever you are placing, we normally say the late placement of implant. Here we'll find that the area is completely healed properly and you can easily go ahead with whatever kind of the bone density is there. Depending on that, you can select the implant and go ahead with the procedure. That only the placement or placement and even the rehabilitation. Whenever you are placing an implant, there is some protocol which we need to follow. That there has to be 1.5 to 2 millimeter of distance between a natural tooth, both with the natural tooth as well as from the apical. It's not only at the crestal region you find 1.5 millimeter and you try to put the implant very close to the root. No, at least 1.5 to 2 millimeter of space has to be there all through to the tooth surface. And between the two implants, try to maintain the distance of minimum of 3 millimeter. You can keep it more than that, 3.5, 4 millimeter will be okay, but not less than 3 millimeter. Whenever you are placing an implant in the anterior region, in the cement retain processes, whenever you are putting, then you can have a slightly lingual to the incisal edge. Your emergence of that can come at the incisal level slightly on the lingual side to the incisal edge you can treat them. But in case if you are going to go for a screw retained processes, in that case, the emergence profile of that thing and the orientation has to be there where the exit is coming, or the drill exit, or the screw hole is coming in the cingulum area. Means you have to place the implant little more laterally. There is a diagram where you can there is an implant where you can see where we have shown two lines. A line orientation of placement of the implant is for the screw retain processes, and the red line is going to give you an idea about the orientation of your implant placement for a screw retain processes. And whenever we are placing an implant, we try to take, if you are placing a single implant, then you try to make it orientation between the central fossa of the two adjacent, and along with that, along the same line, try to maintain the central fossa of your place where you are going to place an implant. That central fossa should match to the adjacent central fossa of the two teeth. Then only biomechanically it is going to be correct. We see that little bit on the biomechanics, implant biomechanics, because this is also very important for one, as even as a beginner to know and understand that in case if you are placing an implant, try to place implants exactly parallel to the teeth, whichever side you are going to take it. Because if you are going to make any kind of ambulation, then it means that the processes which will give is going to give you some kind of increased torque or the load to be borne by the implant. We say that whenever there is a variation of 10 degree of implant from the longitudinal vertical axis, if we have gone for a 10-degree even gain, which will increase 5% of the torque. So depending on every 10-degree change in the angulation is going to increase your additional torque. And this torque normally is not going to give you the vertically, it is the crestal region which is going to get affected with this. And you will find the marginal bone loss more in these kind of cases. And since they are going to give you a stress, modification has to be done. So the stress biomechanics actually comes here. More we have to understand about the biomechanics is about the prosthetic aspect of it, because we ultimately it is the processes which is going to bear the all your occlusal load. So where exactly it should be done, we know that each 10-degree cusp inclination is going to give you a 30% increase or decrease in the torque level. So do not try to give simulate a natural tooth cusp whenever you are giving an implant crown. You must always try to reduce it to the bare minimum, whatever is the basic requirements. Because if you reduce the angulation of the cusp, more so you are going to become more favorable for the processes to land and lesser amount of load going to be borne by the implant. Occlusion, whenever you are going to, must explain the patient or inform the patient right in the beginning itself, because you cannot going to replace a particular implant with giving you a natural type of crown. Since the dimension of the natural tooth and the dimension of the implant is going to be different, if you try to get a natural tooth crown size, then in that case there is going to be a cantilever or offset load on both the sides. So whenever implant is given, it is normally 30 to 40% smaller crown size is given. We are talking about the occlusal table. We are not talking about the complete implant size, complete crown size, but at least the crown of the implant should be 30 to 40% smaller than the natural sound. So we say that instead of whenever you are going to replace a molar has to resemble something like a premolar, which you can see here. So whenever we say that timed occlusal contact. Whenever you are placing a single implant crown, we have to ensure that when the individual is biting on a lighter force, then the implant crown should not come in contact with the opposing tooth. But yes, the opposing tooth come in contact only when you are giving a heavy bite. This is known as timed occlusal contact, that whenever you are biting only heavily, then only the implant crown is coming in contact. Occlusal contact position is very important, because we normally say that this is the area where exactly the load is going to come. The red mark which you can see these two crowns is basically the central fossa, where actually the load or the initial impact should come in this region. So primary contact should be there in the central fossa region, and the green dots are the secondary contacts. Normally has to more than 1.5 millimeter from the margins. Normally with the implant crowns, there is the marginal contact, because they are going to act like a lever, and you
So I'd just like to sum up the for whatever has been dealt till now, like for a successful implant treatment that we are planning. Now there are few things that have been taken into consideration. One of the first most thing is appropriate patient selection has to be done. Based upon all the criteria that have been discussed, the intraoral examination, the extraoral examination, and specific to implant treatment planning, the selection of the patient is of utmost importance. Then a thorough surgical and prosthetic planning has to be done. So as you must have attended so many of different conferences, webinars, talks, and everything. So implant practice is all about prosthetic planning, because the patient comes to us for replacement of teeth. That has been considered thing, and based on that, back on the setting of the implant has of the is utilized when we are planning an implant processes or an implant treatment for a anterior tooth. Whether the processes that we are going to plan can be a cement retained or a screw retained, a lot depends upon how we are planning the case and how we are executing the plan. So correct surgical technique again is of importance, because based upon that you can take a judgment what is the position that you would want the color of the implant to be, and how you would want the processes, what kind of a processes actually are we planning on top of the implant that we have surgically planned. Primary stability of implant is a very big thing that is to be taken into consideration, because majority of the cases that we are doing now, primary stability, one would be in case where edentulous cases that we are working upon. So the kind of sequential osteotomy that we are planning, the kind of implant, the thread design and all that have been selected, that will help us in deciding and taking into consideration what kind of implant stability can be achieved. Whereas in cases where we are doing immediate implant placement, or for other reason, if we are extracting the tooth and then we are going ahead and placing an implant, now achieving implant stability is a key to success for a successful implant treatment. Now here the primary stability is to be taken, or is to be taken into consideration in the apical part, that is the apex of the root. So at least 2 to 3 millimeter beyond the apex is the region from which we are to gain stability of the implant. We never take primary stability or the stability of the implant from the lateral walls of the socket or the alveolar bone, because that is the bone which is the first which is going to be undergoing the pattern of resorption. So the stability, which whenever we look forward, we are trying to engage an implant into the socket and we think we'll put graft, we have stabilized the implant, there are very less chances of happening into such implant planning. Management of soft tissue is again very important, because the kind of soft tissue that is present in adjacent to the bone, the vascularity in the adjacent bone is a lot more dependent on the type or the kind of soft tissue that is there. The viable, the osteoblastic and the osteoclastic activity, all processing has to be done from the vascularity that is achieved from the adjacent soft tissue region. Now, well designed and executed restoration, because see, there are two things for a successful implant practice. One is implant placement. If we have taken into consideration the surgical protocols and all other key factors, the implant is going to osseointegrate properly. Now, whether it is going to last us for how long or a lifetime is a lot more dependent upon the kind of processes that has been worked upon and how in a so for that reason, in the biomechanical factors plan, most of managing and making a whereby we can monitor the kind of attacks. If there are any interference, unusual occlusal loads, we need to alter and remove them. Definitely, nicely placed, because there are processes there and there are certain overloads which are happening. They are ultimately going to hamper the long-term success of our implant treatment. For that region, initial is the implant surgical planning and the prosthetic part. The next is a long-term follow-up process. So ideally, what we practice in our clinical practice is at least an yearly follow-up, whereby the occlusal contacts and all are checked. Any adjustments, if needed, are done. The reinforcement of the maintenance protocol is reinforced in the patient. Now, common mistakes that all of us can happen to do in our day-to-day implant practice. They can be not establishing adequate oral health and failing to adjust to the treatment plan for the bone available. So, if the surgical planning that at that time the considerations have not been taken into account, forgetting the fundamental principles of occlusion while doing freehand placement. Now we are doing freehand placement, and like discussed by sir in earlier slide, if we are trying to simulate the occlusal scheme that is existing in the natural teeth. So now that is different as in case of an implant treatment or when it is present in a normal occlusion. So we need to understand how it is different, how it is having some deleterious effect, and how we can minimize loss that are because of restorative tooth is one of the biggest examples we encounter. We are doing interior rehabilitation Now, if we haven't done a planning earlier and a freehand implant, now the angulation of the implant can usually which have difficult restoration. Now, the problem is today, like say earlier, has come to the not come to plant. The revision of the missing tooth or the aesthetic is of prime importance to us. Engaging in shadow placement now because of the gimmicks and the promotions that the companies are promoting, they have introduced because many a times we encounter situations where good bone is not available. So the company introduced short length implants. Now, short length implant maybe a length of 8.5 mm or a less of 6 or 6.5 mm. Those are shallow implants. They have to be used very wisely. The only point that we can share at this juncture would be shallow implants should never be used as a lone standing implant, and that too when we are using multiple implant in the as a distal most implant, it should never be used. It should be avoided at maximum time whenever it is possible, wherever possible, because nowadays we have the advantage of the CBCT tool, which gives us an analysis of the bone available, of the bone volume in 3 dimension, of the vital structures that are present. Taking help of all those aids, we can definitely have a concrete treatment plan and we can execute it in the like manner. Not getting attention now. This is about the soft tissue closure, because many a times if we are not very trained into the soft tissue closure, what we always attempt, if we have done a surgical placement of implant, we would want to pull the tissue, we would aim to achieve a tight closure, which is actually not a right way to be done, because whenever we are doing tension closure of the soft tissue, we expect some kind of dehiscence to happen. We expect some kind of fluids to enter into the osteotomy site, which are eventually going to affect the long-term success. The integration in the initial surgical stage only is going to be hampered because of that. So we need to take consideration of all these things, very small things, and then weigh a plan. Now we always try weighing the plan of intraoral examination, the surgical planning, the prosthetic planning. Based upon that, we need to formulate the treatment based upon the patient needs and limitation. Now again, patient has come to us for replacement of teeth. So we need to have that consideration in mind, and the limitation which can be at the end of medical situation condition of the patient, which can be at the level of the bone or the condition of the soft tissue that is there. Again, a very common thing that we encounter in our practice is the finance that can be involved along with the treatment. Keeping into consideration all these things, now we preconceived thoughts means we should not be planned that okay, this is the kind of implant placement we are wanting to do in a particular situation. No, please take a guide of all these factors patients need, what are the limitation, what are the given condition, making a balance, making a tailor-made customized plan, then go ahead with the treatment plan for the implant practice. Now here again, because of all these factors, we will understand that professional excellence versus financial excellence. See, financial excellence is going to follow whenever there is a professional excellence, whenever you are executing well elaborated treatment plans, you are executing them nicely. Financial excellence cannot be stopped. Eventually, maybe it can be slow, but eventually it is going to come. It is going to follow. So professional excellence is something that we need to aim at, because nowadays what is happening is we fail to understand one thing, that we are into dental practice. We are all dental graduates at least. So we have had a technical education of whatever dental procedures we are doing. We did a study, we had a training, then to enhance our skills, we attended certain workshops, we improved our skills. If we got opportunity, we have done, we pursued post graduation. If not, there are beautiful courses, workshops which enable us to help us improve the skills that we are having. The only shortcoming as far as implant practice goes is what is happening is in implant practice, majority of the time we are layered with the courses, short understanding without having a deep understanding, scientific learning of the uh, discipline that we are wanting to pursue. We simply have a very small experience. We try to incorporate that into practice. If we succeed with the implant placement and a good prosthetic outcome, we are feeling that yes, we have accomplished something. If not, we miss upon that. Now, to enable or to have a successful long-term planned implant-based practice, we are supposed to have a scientific learning, understanding the need, understanding the science behind implant practice is of utmost importance. Based upon our study, our understanding, we train ourselves, we gain training, we specialize into the procedures, because implantology in itself is a big discipline. It can vary from the basic implant practice, it can go into advanced the procedures, bony procedures that are there. There are so many things, so many dimensions added to it. Sterilization and asepsis again is one of the common thing that is missing in so many practices. Even eventually, in a short run, we might not recognize the importance that it can have or it can play a role into a successful practice. But sterilization, because we are invading into the bone, we are playing with the bone, we are opening into the vital structures, we need to have consideration of all these things. So we need a surgical implantology, thorough understanding, thorough knowledge. We need to understand implant biomechanics, because surgical implant placement is one aspect, just one aspect, believe me. If we are talking in terms of a successful implant practice, a surgically placed implant, the rehabilitation, how it is planned and how it is done, and how we are able to maintain it over a period of years will help us decide and measure for ourselves, are we doing an implant practice or are we into a successful implant rehabilitation which will serve the patient for many years to follow. Implant prosthodontics is something which is going to help us take care of the plant treatment for a particular patient. So all in all, I myself, Dr. Rohit, and Dr. Pandey sir, along with me, we are having our own academy for clinical implantology here in Delhi. The only focus that we have over here when we have designed any dental programs, like for example, implantology courses, the basic implantology masterclass, the aim with which we are promoting it, we are conducting the workshop or the courses is solely that the doctors should have a basic and insight understanding, because there is no set discipline, there are no set books that will help us decide. So the structuring of the course has been done in such a fashion that we are able to engrave all these vital importance of the courses, the discussions along with the video demonstrations, case discussions